I'm an assistant professor here at Health Informatics at Kent State, and we are welcoming you to today's webinar in the KSU Health Informatics Pulse series. Let's do a little bit of housekeeping before I introduce our speaker today. Housekeeping, we want to make sure to mute our telephones and or computers once we get started, just to prevent some background noise. Secondly, your questions you may have on the presentation, feel free to enter those in the chat box and send them either to the group or to myself, or afterward you could also just unmute and ask your question directly when Mr. Carroll is ready to take those questions. So let's go started. We're going to be hearing a presentation on protecting electronic health information in the context of meaningful use. This is presented by Mr. Jim Carroll. Mr. Carroll has more than 40 years of experience as an information technology professional. He currently serves as the director of the Northeast Central Ohio Regional Extension Center, a program of the Akron Regional Hospital Association. Since June 2010, his center has assisted more than 950 physicians in their 11-county region to implement and go live on EHR systems. More than 30 of those physicians have attested to meaningful use and incentive payments. Previously, Chief Information Officer and Vice President, as well as the Security Officer for Sister Charity Health System hospitals in Northeast Ohio, Medical Center in Canton, Medical Center in Cleveland, and St. John Medical Center in Westlake. Jim directed projects for the International Monetary Fund in Washington, D.C., implemented distribution requirement planning systems for the largest distributor of industrial fasteners in the United States, as well as one of the largest electronic component distributors in the United States, and served as the Director of Warehousing Systems for all of General Electric lighting facilities across the United States. He's a national high school instructor and as an adjunct professor at the University of Akron. We are very pleased to welcome Mr. Jim Carroll. So over to you, Jim. Welcome.
Well, thank you. And so let's get ourselves started here. Possible. And so we all know from the Mission Impossible, they are, here's your mission, and if you fail, they'll disavow. Well, boy, wouldn't it be nice for our physicians if that's what civil rights would do, would be disavow. You see the most recent a $4.8 million fine. As we said a moment ago, my name is Jim Carroll, and I'm here today to talk about HIPAA for use and the Protect Electronic Health Information requirement. The topic is getting a lot of attention today. Maybe we read something about breaches out there, and so let's try to give some clarity to what we need to do. Beck talked about my background. I am an IT geek from a long time back and worked in healthcare, systems in healthcare back for small practices. And I always would say to them, why can't you guys embrace IT a little better than what you're doing? Then all they did was use IT for practices and for billing, not electronic health records. Today, on 3 points: requirements for protecting patient information, and some examples of the privacy and security resources that are out there. 4 years ago, this was very scarce as far as available to you, but now there's quite a bit. then give some basic guidelines to assist in completing a risk analysis and management plan. Now, it's important, those of you in psychology don't know the group, but the guidelines are the same whether you are a sole practitioner in Kent, Ohio, or whether you're at the Cleveland Clinic Foundation. And that, these little small practices aren't going to spend the same kind of cash or have the same resources. Let's talk first of all about what the requirements are for electronic health information. It's quite interesting what the objectives are in the marketplace today. The HIPAA is way, and I always have such an enjoyable time when I walk into these practices, and I did just literally last Thursday, solo practice, solo provider, and a big sign there that they were so proud that they support the HIPAA security rule and that they were signed by everybody, and they had HIPAA spelled HIPPA. And I pointed out to them, I said, well, that's very nice that you support. It just doesn't seem to be the rule that you need to support. And I walked through everything with them. They truly did not understand what is a security rule. HIPAA was put in place as part of the HIPAA. We all know HIPAA privacy was out there for the paper-based. Well, now HIPAA security rule, sometimes referred to as the high-tech rule, is driving in. For a small practice, it's very long, 115 pages, and it drives out that they need to have appropriate administrative.
I'm going to interrupt you, Jim. I'm so sorry. If everybody could put their headsets and phones on mute, that would be great. We're getting a little bit of background noise. Thank you.
So what we have to do is we have to dissect what the rules are and what is understandable for our folks that are out there. So the security rule was out in place long before meaningful use was out there. And when we have to look at this, a lot of folks say, well, we're not going to do meaningful use, so we don't have to protect electronic health information. Each of us are consumers. And if we're dealing with somebody who doesn't think they need to protect our electronic health information, we've got some issues. Talk to the former Chief Information Security Officer at Target and how they like it. So we've got the HIPAA security rule, which is the foundation. 115 pages, very confusing, built the National Institute of Science and Technology, the NIST standards, and it's very challenging. So for use, and it came out with an objective: protect electronic health information that's created or maintained by the certified EHR technology through the implementation of appropriate technical capabilities. Really to understand there, it's only 19 words as opposed to 115 pages. Our docs think they've got it made. I had it made at the hospital when I first saw this, and I was doing this in 2005, and then when you got to the actual measure, it points us right back to the Unified Federal Regulation 164.3. And it requires you implement security to do security risk analysis. And it is challenging because it is not clear as to what is the appropriate. Physicians like, because that's the way they think, black, white, binary, either this or that. They don't want shades of gray. Measure was pretty straightforward. State, which took effect as of 2014, and I'll put those of you that may have heard me speak a moment ago, that changed the rules a little bit last night, and I have no idea how it's going to affect this. But in stage 2, the only difference was now we have to use encryption. And they have to encrypt data at rest. And I assure you, those of you that don't work in a IT world a lot, the term data at rest can mean a lot of different things. And encryption, the bar for encryption, but they're addressable at this point, and be I see stage 3 rules come out, encryption now be mandated across all areas. Anybody who deals with electronic health record, I expect in stage 3 in 2016, they're to require encryption across every aspect. We know that we know what the requirement was. Do a risk analysis and have an arrangement plan to address whatever risks we find. Moving forward. So they are looking at what are the resources available for you, your practice, your hospital, your company. So we walk out and we start realizing in this practice, to get down here at the bottom, to protect electronic information, you have to coordinate all these regulations, and they are multiples in there. You have to, CFR 160, 164.308, 164.306, they both point back and forth to one another. You've got technology. You got to figure out, what am I doing with encryption? How does that work with my EHR vendor? And it's all 2014 certified prior to 4:30 last night. So this world that our practices and hospitals are trying to deal with, how do I do this? We'll go to all this to you. The presentation will be available to you out there. There's links at the end. Point out a couple key things. You're going to all the federal government, when they put this together, breaks down confidentiality, intent, and availability. So your CIA, and normally it's on a triangle with the on each side. Confidentiality is what it stands, exactly what it says. Make sure it's kept private. The piece is one that is in a that people don't catch on. You want to make sure that you're not doing something if the EHR isn't deployed in such a way that the electronic health record could be corrupted because done incorrectly. And then is the gotcha. It's got to be available. If you get a call from a practice and say one of your patients are in there, we need their last test results, you better get to that. And in the paper world, you used to be able to go pull a paper chart. In the electronic world, what happens if your system's down? What happens if that's down if you're cloud-based? These are all things that practice needs to worry about. They know where it is that creates, receives, maintains, or transmits. It's that they take all reasonably anticipated threats or hazards into consideration. That's, for those who have done this, maybe there's a thing out there called a threat vulnerability statement. I love these because that reminds me of somebody who sits in a room with nothing better to do and says, hey, what, today when I go outside, a meteor could hit me. There could be a speed of elephants that could come down the road. I mean, you can come up with every kind of potential. And they will sit there and tell you, we have 5,000 threat and vulnerability statements. What's reasonable for a small practice or a hospital? That's what the government wants you to look at. You need to address things that are not reasonable. But you can't sit there and say, we don't have any problems. You know that you did take some reasonable steps towards mitigating the risk. You also have to make sure you think about any anticipated uses or disclosures that are not permitted. Into that is you've got to make sure your policies are in place. You got to make sure that your employees know that if there are requests for information, what is that limited data set that they're allowed to send? And in terms, it means something if you're in the HIPAA world. You got to make sure that your workforce is trained. You're not there and say, yeah, we've got a nice policy book. It's sitting on the counter over there, but none knows what it means. You have to make sure the workforce is trained. There is some flexibility here. Use any security measure that allows a covered entity or business associate to reasonably and appropriately these rules. So right, if that's nice and clear. Any security, they're not going to tell you you got to do A, B, C. They're going to allow you to choose what's reasonable and appropriate. I'll buy a solo doc in state, Cleveland Clinic Foundation, are going to have the same rule, but what's reasonable for the solo doc would not be reasonable for clinic and vice versa. You're into consideration size, complexity, and capabilities of that practice. How are they able to do these things? They take a look at the technical infrastructure, hardware. I can tell you, for those of you that are planning on going out into this marketplace, you'll find many a practice where the physician may be the IT person, maybe biller, or you're going to walk into a practice that maybe has 75 to 100 physicians, has a full-blown IT department. They're both going to have the same set of guidelines they have to follow, and they are both going to have to figure out what's appropriate for their organization. To be taken into consideration, but you don't. There's enough frequently action out there that clearly states cost, though, cannot be the only reason in a solution. You may the cost of implementing a entrance to the office may be expensive. And you could sit there and say, well, it's expensive for us to secure the door office. No. The answer is you put a key and a lock on it and you give somebody a key. You can't just use cost as an example. You have to use what's reasonable. Must comply with applicable standards. So not to sit there and say, I don't want to do this. If you're a covered entity or associate of a covered entity, and that is another challenge when the HIPAA omnibus rule changed last year, they put these out to the business associates. And most practices at that point, and hospitals, because I know I got a lot of them, read their business associate agreements, and a lot of them, though, failed to do so. Actually, they would be in default and out of compliance with them right now if we go out and audit them. So you must comply. You don't have a choice, but how you comply is that these terms cause all sorts of problems in the marketplace. Information specs can be either required or addressable. If it's required, you do something about it. You must implement that specification. That specification, again, is up to you, but you ignore it. And look at cost. You need to look at what are my risks. You need to look at what options there may be, but you have to do something. Addressable specification, now you assess, do I do this? So there, you assess whether each implementation spec is reasonable and appropriate. And not, well, that really doesn't apply to me. I'll give you, when I go to a small practice that has 3 employees, I don't think it's real important that each of those employees have name badges on. They know who each other are. I would say that has 30 or 40 employees and need some name badges. I practice that has multiple locations with floaters, absolutely you better have some IDs. So addressable side. Again, is it reasonable? Is it appropriate? If it's not a reasonable and appropriate, you just don't get to sit there and say, I don't need to do it. As many of my practices just simply said, nope, nope, nope. You need to say, because the auditor's going to ask you why you choose not to do that. Risk, is that the first thing you're going to look at? Was there risk? Because this is what the key of when we do risk analysis and when we work with these practices, we're there to find what risk is there that we're going to lose or we're going to reach, the safety, the confidentiality, the integrity, and the availability may be impacted. If they're impacted, we have to take some appropriate steps. And the little piece of maintenance that the feds put out there, you must review and modify as needed to continue doing this. Many practices thought they had to do this once and they could forget about it. Anytime there's a major systems change, anytime that there are procedures, if you have significant turnover, you need looking at these and perhaps making changes to your risk analysis that are available out there. And what's sad is most resources are difficult to follow. They're just simply citations of the Federal Code of Regulation and not really in a understandable term. A couple of these, if you go out to these things, you're going to see this is the HHS for small providers and health plans. There's the summary of the HIPAA rule, good 115-page. If you've got problems falling asleep at night, that will cure it very quickly. In some more guidance on the security rule, these will lead out to sources that you can. I'm going to jump to. You'll see the Health IT Gov and walk you down through. They've got the games. They got a new game out here, Cyber Secure, and you can play the game. They've got one on business continuity, but they draw all these different pieces out here. Which again is there's a lot of options out there, and it's for the practice to figure out when they need to. So there's a document here. First of all, I'll talk about this one. This right here, if I had to tell you to download and refer to, because together this real guide, and it will lead you down through all the different sections required for. You actually put together quite well. And so I would suggest if any of you are really wanting to drop into this, know more about all the different steps, this document right here is far the best of them put out in a while. There's also a stage 2 guide out there for meaningful use that does address some pieces, but it's worthwhile to look at and understand some. So they have, if I can find here on the side, which I'm not going to spend any time. Out there, it's called the 10 myths of security. It clearly tells these practices, do it, but there's no right way. Just make sure you do something, and that uses them every time. We released a security assessment tool. It's in development for months. And you can go out and download this. And the problem that we have, because I was actually part of the development of this, that we have is the security risk assessment. And you not do a security risk assessment, you have a management plan that says how are you going to address those. And we're going to have that here in just a moment. So right here, you can download it. It's available for a Windows environment. You can download it for an iPad. You can download it also. It's available on an Android as well. It's the top 10 myths document that I was talking about a moment ago. It's optional false. You'll see a recurring theme here. Every answer is false. But look up. It's another good one to do. I'm just a moment. You're going to see a reference to it. So the sources, and I believe we're going to have the information available with these in it, so you'll be able to go out and get these. So that's meat and potatoes. What is risk analysis and management plan? You hear me prefer this as a ramp. The risk analysis and management plan is the first thing the auditor is going to ask for. Right? You can get audited if you're into meaningful use from a group called HIPAA. Will come around and ask you to show us inventory, show us your risk, and show us your management plan. If an Office of Civil Rights audit asks for the same thing, they want to see that you've updated it and current. Oh, this is right out of that, and this is what gets very confusing to our practices. Is there a risk analysis method that I must follow? Wouldn't it be wonderful? They said yes, and here it is, A, B, C, D. Still, it can right out of the 10 myths. Yeah, it's not described. You just do that a risk analysis is important. And you need to do some form of management plan to assess whatever the risks are that you find. Practice. Here's a 115-page document. And I tell you, though, that there's no right way to the way is not to do it. Okay? Go do something. IT in the hospital, I used to use a here's some technology, go forth and compute. That's the quickest way for me to fail, and this is the quickest way for a practice to fail, not to understand what to do. That we have to do, and if a practice does this, they need to reach a culture of compliance. Remember this, a physician is going to come after. So when I talk to these physicians, you're the one who is going to be sued. You could wear a striped suit if they're real ugly. So it's important that you set a culture of compliance. You sit there and say, do what I say, not as I do. Right? Those of you that work in this industry know we have a problem with mobile devices. And physicians have been trained and raised using and where they type in some of the most information and they just send it out. Sometimes that's good, sometimes it's bad. I've got physicians using Gmail, which I very quickly tell them don't do that. But it's important that leaders set up right from the get-go. Procedures are put in place and train and educate the staff to understand. You need to have an ongoing training program. The quicker you get yourself upside down in an audit is when the auditor comes in, and when I did the audits, I would come in and talk to every employee. I would ask them, do you know where your HIPAA manual is? Do you know what it says? And give them some questions. And the thing that bothered me more than anything is when I get a new employee who had been there for more than 2 weeks and they had no idea about any of these things. So think about that. New employee gives away patient information because they weren't to. Probably in the end, it's going to be in a world of hurts. An audit file. The feds tell you need to keep your audit file for 6 years. I know we've got somebody on here from Cleveland, and up there, one of your meaningful creates a book, and it's a nice. I saw him do a presentation on it. It's a really good, thorough document. But you need this to be able to cover your space of an audit. So yes, we did this. We did this on these dates. We did training, policies and procedures. We update our policy and procedures. If you practice, if you see when policies and procedures were last updated, Well, a practice, not only do you establish a policy, you establish a review date, and you put that into some form of a calendar or reminder file so that those policies grow stale, and that you're showing that you have this culture of security, culture of compliance. Another practice always has to do, create an inventory of all electronic protected health information. Now think about this. When you walk into a practice and I do these audits and I do risk analysis, they'll tell me, well, my EHR vendor, that we're good. Smile and say, that's wonderful. Do you use any thumb drives? Do you have any CDs? Do you have any, I could go through a whole series. And 90% of the time they go, yeah. Well, does the vendor know about those? No. Well, a good thorough inventory of all your electronic protected health information. It's impossible for most EHR vendors to do this remotely. Actually, it's quite difficult for most people to do it remotely. They go on site and challenge and do a walkthrough. It's thorough, and it's actually because this is the basis. Risk implies that we have an asset. That asset is at risk. Well, it is our inventory of all electronic protected health information. So if that's accurate, think about it. If all you tell me is you've got electronic protected health information on that computer at the front desk, in that back room you've got these CDs that nobody's watching over, we've got some potential risk. The inventory of all the ePHI, at that point you do a full-scale security risk analysis. Now, what does that mean? We already saw that there's no definition of that. So if I'm at Cleveland Clinic, is going to probably be far encompassing than I'm down to the solo doc out here in Kent. But thorough for my appropriate needs. Then we dealt through that, and we start to look at risk. When we do risk analysis, I'll give you an example. I can walk into a practice, and their server sitting right on the desk, right behind the counter that has no window on it. Somebody could jump across the counter, grab that, and run out the door. So that's high risk, but they're been done. If that PC server was encrypted, the risk of it being stolen is high. My risk of a breach is nil. So it would be good as far as a risk for data breach. But now we've got within our risk analysis, we ask questions like, what's your continuity plan? Back up and running. Server stolen, do you have inventory of all the software that's on it, the model number, everything, so you could replace it quickly? These are things you have to look at when you do a good risk analysis and develop the maintenance plan. So in this case, we have to say it's encrypted. If we don't have inventory to replace it, and bet where all the software is located needed to replace that. So you can begin to see this is much like lifting stones, and on their own you find something that you didn't know existed. Same every time we do one of these. The practice needs to have is policy procedures. Back in the thing I told you, the addresses administrative, physical, and technical. Well, the administrative side is 90.9% policy. Got to make sure that this is crazy, but you got to make sure you have a policy that sanctions employees who do something wrong. On this website, you go through it, and you'll find a videotaped Attorney General training, because now state Attorney Generals can get into the fray and against a practice. And they talk about, they give an example, and they really say, oh, they don't have a policy for sanctioning the employee, that's an additional amount you can go after. I mean, they're looking for every opportunity to get into this fine. And so the practice. Finally, ensure that we have a good communication plan, that we know why we're doing it. if we all put our consumer hats on, everybody who's dealing with our personal information is doing everything they can, and they ought to be telling us what they're doing. You know, our banks are good about that. They like to send us out all these things saying, we're doing this, we're doing that to protect your financial information. Well, right now, your electronic health record tomorrow for $50. So they sound like much, but if a laptop that had, pick a number, records on it, $6 a piece, I just made myself a lot of money. And these are the things that we need to be worried about, so we need to communicate to our patients, to our staff, and our vendors why it's important to protect our health information and what we're doing about it. And make sure all our business associate agreements are following the new guidelines, and we make sure that our business associates are doing what we tell them to do. And, you know, real sad, my ophthalmologist, back in October of last year, he diagnosed me with some things that were and in my eye, and so I said, okay, good. Lucky we're Cleveland Clinic. They took care. Jim calls me and says, Jim, my backup company that none of my backups for the past 2 years are good, and the server just crashed. His first comment was, how are you going to attest to meaningful use? Not what about all the information I lost? What potential liability lawsuits? And after about $15,000, recover all that. Having doing with business associate agreement, risk analysis with his vendor, and ask them, how frequently have you attempted to restore using backups? He would have did this. All guys together to come up with one big mess, so to speak, or a practice. Think about it. So not to do clinical, he has to solve all this. And this is where he can come in our industry and help add some credence to it. So what we do, like I said, we start out with an accurate inventory of HIPAA. Real simple. What's the where it's located? Does it transmit? Is it encrypted? Is it critical? Is it in the cloud? Is it local? I could argue all sides of which one is more secure. A risk analysis. Some of our physicians have been trained in the SOAP approach of subjective, objective assessment and planning. So what I did, I created a method that along the subjective, we do a privacy and security checklist, we do evaluation, we look at all existing controls, and then we put together a management plan. And we continually do this. And this is a never-ending story. So we gather our data, identify the threat, what's the cause of a threat, what would be the impact of a threat, if it did happen, my risk, what current security do I have or current measures using, I start all over again. We have a very basic tool, and this is right out of the federal government. Now, do you have formal sanction policy against employees? The answer is no. That's complete. And here we tell them what sanction policy. Because of our physicians who say, yeah, we tell them they're going to get in trouble. I have somebody pass the law, you're being sued $1 million, do you think that's going to save you? And most people will say no. So as we dive down into this, so here was our risk analysis, down our management plan. We don't formalize sanction process for employees. Talk all the way through. We have to say who's going to do it, when they're going to do it. This is what the auditors look for. They look at practice to have said, yes, I use risks, and here's how I'm addressing them. And yes, for about 50 and a couple hundred, depending how big you are, kind of issues. So what this does, so that they can meet the risk. And measure, like I said, that's not complete or in progress, you got to implement a risk for it. Some of our physicians, They risk analysis, and they got to do the policies and procedures, make sure what to do if it's lost or stolen. That's where a lot of these fines come, because they're sure how to notify patients if they breach. You that have heard of the wall of shame, if you reach more than 500 names, you get to go on that list. You can go look at it on CMS. We've had a local hospital here who I'll tell you what should scare each of us. If you look along, some of these were a breach before they caught them. Some of them had been breaching for months before someone realized it. Make ePHI is encrypted. Who gets a CD from, comes in, and the patient them a CD from their other doctor in a filing cabinet right next to the front desk marked confidential. And they own that ePHI as soon as they take it. They need that policy and procedure that says as soon as you give me this, we're going to copy what we need and destroy your CD. And in this, we're going to protect it until we do. You got that you can know if a patient doesn't want information shared. That was a change. If you're case, they don't. Your company has no reason to understand to see what you're doing. You better have the ability to flag that and make a process that says that. You got to be able to send patients their health information in electronic format. You got to update your practice notice of privacy. That's what they got to do. And open to practice clinical medicine. So it's a challenge out there for our physicians. So this is a 3-day deal, and it's challenging to try to put in a 35 or 40-minute present. But confused people, please ask questions.
This is Becca again. I wanted to encourage the group to either send me via the chat, send me a question that you might have for Jim, or type in and ask it yourself right now. I'm going to start out, Jim, with a question that we had about mobile devices, and then again, others can feel free to ask. Just given the rapid adoption of mobile devices that are with us and basically that we're encouraged to use, what is your experience in terms of best practices with maintaining security on those types of mobile devices, specifically iPads and cell phones for transmitting patient-related information?
The number one question that I receive when I walk in and out of practices. And this again, if you ask me, and I'll answer here. Can I use Gmail? And you shouldn't. Can I use Gmail to send an email to my patient? And if you read the answer, and there's actually an FAQ out that says, sure you can, as long as appropriate safeguards. Again, left, right, what side of the mouth are they talking out of? So back to this idea about mobile, you can use mobile devices, but you have to protect information. So to take a phone and to you kept it and you didn't do anything to protect it, you yourself trying to answer the question, did you reasonably anticipate the loss of data or the improper use? Things that we tell our practices. We tell when you do your with your patients, you need to ask them. I share information with you via email, and they're put in writing, understanding that email may be non-secure. If the patient tells you, yeah, we can do that, then you're much to being protected. Now, there's still some out there, I'm sure, that if it was stolen and they could prove that you had not done anything to protect it, we'll try to after you. That's just the nature of our society. But for most devices, I tell everybody, if you don't have to use it, don't use it. Have encryption turned on. Make sure you have logins in package. If you use some of these phones that are out there today, some of them wipe them remotely. You need to understand all of these capabilities. If you've got, do not store unless you have no choice. Do not store any ePHI on these devices. They can be stolen. They can be. You've got it encrypted. You get out of jail. No, not that you're in jail, but that's your way of avoiding having a breach. So, and for me to sit here right now on my phone, to sit in Dr. Carroll, and I want to send it to Dr. and say, this is, can I send it? Well, if there's any problem, that's usually the physician's response. Nobody until breached. And then breached, you've got a problem. In the beginning of this thing, Becca, I showed these different settlements that are out there. These settlements, because the feds don't get paid everything they're supposed to. One of my presentations, I show where a 1,500 name laptop, a laptop with 1,500 patient names was lost. It ended up to $19 million of fines.
Wow.
Yeah, you correct yourself.
As a follow to that, if one of your listeners and is hearing about this right now and have some concerns of their own as an employee of the hospital system, where they perhaps have not been hearing enough about the risk analysis or management plan as an employee, what would you recommend to the frontline worker right now who has not received enough information about this?
That's sort of scary, I guess, because the HIPAA rules, do require all employees to receive training. And if you're not getting that kind of training, I would definitely go back into either HR, or whoever is the compliance officer for the organization, and ask why. Because requirement, I know at the hospital we developed our HIPAA training, and we had to do all this, but you need to understand, because ignorance is not going to get you out of a problem if you violate HIPAA. They don't smile upon that.
I'm going to pause here for a moment and just audience, if you have any questions that you would like to mute your phone and ask.
Information there, you can. The cool things about what I do now is get paid to do what I wasn't allowed to do as a CIO. I get paid to help people now, and without worrying about violating stark antitrust laws. Questions, you can me or you can email me, and I'll get back to you with answer I can.
Question. And read this off. Feel free to unmute your phone and ask this if I ask it incorrectly here. What kind of responsibility does the physician have working for an agency that forced him or her to use her own device, I'm assuming, device or computer, and completely does electronic health record charting from home with little security training?
That's a very good question. I'm actually helping a practice physicians that are all hospitalists right now going through something like that. First of all, if you're a healthcare provider and you are a covered entity, then you need to follow HIPAA guidelines. And so the best I could give to somebody is, if you're being forced to do violates HIPAA, you have the ability to notify the Office of Civil Rights. Actually, if you go out to their website, you know all sorts of information about how to report those things. You can do them in an anonymous manner. But the physician or the caregiver who's doing this, being forced to do this, that's a tough spot to be in, because your job, you got to do it. I would look to see within the organization, maybe they understand. That's what I find most of the time. there's a lot of urban legends out there about what needs to be done, what doesn't need to be done, and using documents that I pointed out here in this presentation, perhaps you could share that one PDF that was there back to somebody so they understand the risk. Shows costs that are there's some out here, $50,000 fee to a two-practice practice. You know, they're serious. But if you're going to have to make a decision as a professional, do you allow yourself to be put in that position? And there are ways that you can report that you choose to do. That is that an assumed risk on your part that you were doing that? And Brian, I'm not saying you are, but I mean, is that an assumed risk that position was taking?
Okay, thank you. Any other questions before we wrap up our call with Mr. Jim Carroll?
I want to back just tell you how crazy this thing is. I had a solo practice down in the center of Canton, Ohio, and this doctor serves the underserved. Does everything. I mean, he's one of my heroes because he's doing it for the right reasons. A patient who felt he had a HIPAA violation, complained of civil rights. Doctor about $15,000 to $20,000 in legal fees to prove that he had not violated HIPAA. So just because you may dodge a fine doesn't mean the practice dodges. So it's really going back to that culture of compliance, making sure that a practice shows its patients, this is what we're doing, and that we're following the HIPAA. We're following privacy and security best practice. And so the question that came up, I would draw home to somebody that they're not quite following that.
Mm-hmm. I think this is a very sobering discussion, and something that we all need to be well aware of. One interest that I personally had with this is really hearing more about your challenges or success stories with getting the workforce informed. Like you said, the organization might have a risk analysis and maintenance plan done, but to what extent does the workforce know about it? I think that's always going to be a challenge. Do you have any success stories or best practices for getting the frontline workforce involved?
Actually, I do, because we're involved in another a large practice here in the area with 7 different locations, and we did analysis for them, and we are doing exactly that. We started with the physicians, trained them, told them, okay, guys, here's all your risk. The next level is we're going to all the frontline managers. The next after that will be group meetings with all employees. That's what you do to protect yourself, and it's all documented so that your workforce does understand what they're required to do. So in organizations we coach on, actually provide them, here's training material, here you need to be doing this training, here's how to document it. We give tests to make sure people are understanding what needs to be done.
If there's no other question, I'm going to take this opportunity to thank you, Jim, very much for your time and information. It has been really enlightening, and I'm sure that you'll have others who will be asking questions at a further date. Thank you for the resources and the links in the presentation. This is all going to be archived on our HI Health Informatics Pulse website. Thank you, Jim, for your time. We appreciate it.
You're welcome. And of course, I have my last piece of the
That is fabulous. Thank you so much, and thanks everyone for joining the call.
Okay.